Today we'll be having a presentation by Dr. Randy Kearns, and Dr. Kearns will introduce him. Dr. Kearns.
Well, good morning. Thank you, Dr. Meyer. The Department of Surgery here at UNC is really known for its innovative research and its role in development of federal health policy. And so we really have had some singular roles over the years, and I think that's really what this Grand Rounds is going to represent as well. It's our pleasure to have Randy Kearns, who has been for the past couple of years the state of North Carolina Burn Disaster Coordinator. While Randy is based here at UNC, he really works with all of the state agencies in North Carolina, Office of Emergency Medicine, Medical Services, the trauma system, and all of the EMS agencies in North Carolina. Randy is a true native of North Carolina. His family has roots in Davidson County that go back to 1740. He has a long history in disaster management, having gotten his bachelor's in this field, and then in conjunction with Fort Bragg in Central Michigan, he has a master's in healthcare administration. Very shortly, he'll be receiving his doctorate, as Dr. Meyer mentioned, in healthcare administration from the Medical University of South Carolina. Randy has over 3 decades of experience dealing with EMS issues, having run the largest two EMS systems in the Carolinas. He's also been involved in more than a dozen federal declared disasters, and in fact, when Katrina struck, North Carolina's response in Waveland, Mississippi was one of the signature programs that worked, and Randy was the hospital administrator of that program. Randy is now in charge of the lead agency for the burn disaster response in the southeastern region, and that's what he's going to be talking about today. So with that, Randy Kearns.
Good morning. It's my pleasure to be here. The house lighting, thank you. As we look back on the 2009 inauguration, there's a couple of things that immediately come to mind. Number one, so why is that important? Why were we involved? Why was that necessary? As we think through that, it's important to also know what type of services we have here and how we're looked upon by the federal government to be able to provide services and support activities both in North Carolina and, for that matter, in the southeastern U.S. So as we look back on 2009, as far as the inauguration, there was a significant event and certainly the potential for a significant event. And I'd like to take you through a couple of the federal planning scenarios of what we thought about and what we discussed. And then also look in context of how that applies to what we see down the road and kind of what the current climate is for what we're dealing with today. So why did the Department of Health and Human Services contact us? Well, first of all, if you look back on the inauguration, there was an expectation that there may be as many as 5 million people attending the inauguration. I assure you, having seen previous inaugurations, there's not really been anything quite like that in terms of a mass gathering. 5 million people across several different areas that were closely congregated certainly created an appealing target to people who really wanted to cause us harm. And even if they didn't want to cause us harm, there are certainly natural disaster planning scenarios that we had to consider as well. So again, in terms of why did they contact us, the burn center itself is a stalwart in what's being provided in burn care in the Southeast and, for that matter, in the United States. It is one of the largest and certainly one of the busiest burn centers, providing some of the most comprehensive care found anywhere. We are well known for that. And as you leave kind of the burn world and get into the disaster management world, there's really 3 types of patients from a medical disaster standpoint that we know we're going to be short in our ability to care for those patients in a critical way. Trauma beds, pediatric beds, and certainly burn beds. Okay, and when I wrap up the presentation, I'll come back to some of those numbers just to drive that point home. But again, the main point is if we know what our scarcity and resources are, it does allow us to pre-position assets and figure out ways to at least be sure that we've triaged, we've sent our most critical needed patients to those areas that need those services most. If we look in terms of the burn disaster program, the burn disaster program, as Dr. Kearns mentioned, is based here at the University of North Carolina, but it certainly serves the citizens of North Carolina, and for that matter, the citizens of the southeastern U.S. We've had a number of accomplishments, but it started out with, we had to write something to get a feel for what we needed. That started out with a gap analysis. What did we have and what did we need? And from the gap analysis, it drove more of a white paper in terms of what type of services should be provided or at least should be available. And as we drove out to different communities and kind of laid out the program and talked to them about what type of services they expected, we also talked about what the national expectations were in terms of disaster planning and disaster preparation. And quite honestly, folks, the feedback we got was, while I understand the national planning scenarios call for us as a community hospital to manage some burn patients for 24 hours, you've lost your mind if you think I'm going to sit on a burn patient in a community hospital for 24 hours. So it does come back to whatever national assumptions we may draw, the reality is what's going on at the local level. And the local level told us in a fairly frank way, we need some help with training and education. If you have those types of expectations, and that is critical to our planning, it starts at the community level. And I'll talk about that as we move through some of the things that we developed. But we developed plans for community hospitals, regional hospitals. Again, it created decision trees. I have children, so I'm used to both, not just the what, but the why. So our first objective was to create a one-page decision tree that helps you with the decisions of what do you do with these types of patients? Who do you call? What type of time frames do we expect some things to go on? And then we developed a considerations document, which is the why behind it. The gatekeeper in most significant disasters is EMS. The emergency medical service system in North Carolina is generally like most EMS systems across the nation. Whenever there is a significant disaster, EMS is generally the first on the scene. Now, they're not always going to be taking care of all of the patients because sometimes, people will self-evacuate, and that's been our experience in previous disasters and certainly will continue to occur. But EMS will generally wind up capturing the majority of the patients with the most critical injuries. So we saw that as kind of the first jumping off point to be sure that we had good clinical care being provided at that level. So we started with the EMS system and helped them with the medical protocols that they had in place and to revise and create those. The next thing was, as I mentioned earlier, we talked about education. We went around the state and continue to go around the state providing advanced burn life support training. Because it does come back to community hospitals will feel more comfortable absorbing and creating some surge capacity within the system for hours, not necessarily days or weeks, but for hours in managing those patients until we can absorb them at the burn centers. So again, the solution to a part of our problem was to look at the local community hospital. Obviously, we created ways that we could disseminate the information. We did that through a website. And then, of course, it's important to be able to fund what you're trying to do. We received $1.25 million so far in the first 4 years of the program, and we have reasonable assurances that the program will continue, although in the face of whatever budget cuts are going on, you never know. But again, our program is well thought of, and I'll also highlight that later on. But it should be noted that there was 2 programs contacted on the East Coast of the United States to develop and work with the Department of Health and Human Services during the inauguration. One was St. Barnabas for the Northeastern Burn Consortium. St. Barnabas is actually in New Jersey, but a suburb of New York, and the other was the University of North Carolina to work with the Southeastern Burn Centers. So obviously, this drives some of our academic work. We've tried to be sure that we've done a number of oral presentations around the country. Sometimes it's poster presentations, just a couple of the poster presentations that we've done. But again, let's get back to, okay, so that's why they called us. So what did we do? First of all, there's a planning phase. you have to go through planning scenarios. What are the different types of scenarios that can lead to a catastrophic event? And again, when you put 4 or 5 million people in a small space that's generally out in the open, exposed to the elements, and the elements that particular day was a high of 38 degrees with a wind chill factor of about 32 degrees. So it's cold to stand there all day so that you can see what certainly was a historic event. But again, it also gives you a large number of people in a very small area that you've got to figure out ways that you can plan for them. Another piece we had to do was capability assessments. In terms of capability assessments, we were trying to measure what threshold could the local resources manage this, at what area did we have to redistribute some patients, and at what point was it completely out of our hands. And quite frankly, that's when it kind of transitions from being a disaster that reasonably you can manage to being a catastrophe that sometimes your best plan there is hope, and I'll talk about that as we wrap this up. So again, just to capture a couple of images of what it was like that day, significant numbers of people, basically as far as the eye could see. Now you can imagine trying to be sure that you've got ample medical services there. The district obviously is federal property, so you've got a city government that's responsible for what's going on there within the city itself. But you also have 2 states that are very close by, the state of Virginia and the state of Maryland, and then you have the federal government that's involved. And there's layers upon layers of being sure that we're not duplicating services. We don't create too many duplicate reports that are going on, and unfortunately that did happen to some extent. But again, as you look at the size of crowds that were there, obviously you can think through some of the particular problems they could have faced. Also note, this is the 18th of January. Now the reason I want to be sure and point this out, this wasn't a 3-hour event on the 20th, okay? This was really a week-long event, and that's why it was important for us to be sure to capture data going into the event and leading up to the 20th. And actually we captured data shortly thereafter, but on the front end, one of the very first things we did before we started capturing data was to be sure that all of the information was correct. And as we talk about the limitations of some of the work, we found that it was not. A document that drove some of our planning scenarios. Now, there are 15 national planning scenarios that are part of the Department of Homeland Security, which is kind of the overarching organization that manages disasters in kind of a broader perspective. The U.S. Department of Health and Human Services is responsible for something called the Emergency Support Function 8, which is health and medical, which is us. So from our standpoint, the people we worked through was Health and Human Services. But again, as we look at these national disaster planning scenarios, those are the 15 most significant events that have been identified by the government as being potential areas of concern, or our greatest areas of concern. And as you can tell, more than half of them actually involve activity with the burn center. Now I'll tell you, again, if you think through planning scenarios, one of the things that you want to be sure you're thinking about is what's the worst case scenario, okay? Now, I'll move through just a couple of the threat scenarios that we looked at dealing with the burn center, but I'll come back to an improvised nuclear device, an IND, because I can tell you there's really, well, we'll cover the data, but the bottom line that I'll offer in the activation, accidental or purposeful, of a small, even small yield nuclear device is we certainly don't have anywhere near the capacity of what we would need to deal with something of that nature. We did look at, like I say, we looked at a number of things that could be tied to the burn center. We did walk through some of the planning scenarios. Obviously, you're probably not going to have a hurricane or an earthquake during one of these events, but again, it was a part of our planning scenarios that we did look at. Radiological dispersal device, and when we're talking about there, something like a dirty bomb, Certainly not to be confused with a nuclear weapon or the use of a nuclear weapon. But it did come back to, this was our worst case scenario, was a 10 kiloton yield device. To kind of put that in perspective, the weapon dropped at Hiroshima was somewhere between a 5 and 10 kiloton yield, and the weapon dropped at Nagasaki was between a 10 and 20 kiloton yield. Okay, to again kind of give you a characterization of how significant this type of device can be. The types of weapons that we have available today in terms of defense or attack are much larger, up into the 2, 5, and 10 megaton yield. Okay, the weapon that was the 2 bombs that were accidentally dropped during a in-flight cabin failure and breakup of the aircraft of the B-52 in Goldsboro in 1961 dropped 2 megaton yield MK-39s at that particular point. Now, it's a 2 megaton yield, which is a much larger weapon that was dropped there. But again, our planning scenario was a 10 kiloton yield. The types of devices that we looked at, it is accurate to report that what was formerly the Soviet Union cannot fully account for some of the smaller devices that they had constructed during the Cold War. We're talking about either a suitcase or a backpack type device. The smallest of is a suitcase device, and I actually have a picture of it. And then the larger is a backpack device, but a backpack device, again, puts it up into the 10 kiloton yield scenario. In this particular example, it's a 3 to 5 kiloton yield, but again, what we were looking at was much larger than that. Okay. And to give you an idea of what a suitcase device looks like, it's basically a pipe bomb. If I can kind of highlight, this is your battery, your electrical source. This is actually a timer. It's not really, not that distinguishable. It's encased in lead so that it's much easier to try and slide it through a metal detector so that it all has a solid appearance. A simple household switch that you can activate either before or after you set the timer. Activate the household switch, and at the point that the timer tells the electrical charge to begin the chain reaction of the nuclear weapon, obviously that's when you have your explosion. One of the academic pieces that we looked at that was probably the most accurate to give us some ideas of what our overpressure would be, our blast pressure would be, our thermal energy released could be, that was a piece of work out of the University of Georgia. It was done in 2007. Again, some of the main things that you could see from that, and I'll show you this particular ring. People in an open area would be exposed to enough calories of heat or thermal energy to create a third-degree burn in an area throughout most of the Washington, D.C. area. Now, this is a much larger yield device, but this was the data that we had available. This is a half a megaton yield or a 550 kiloton yield device. But again, it reminds you that not only what was in the D.C. area, most of those people would have been killed, it also reminds you that you lose the capacity to manage patients in the immediate area in terms of hospitals, and we think about our bed capacity or our ability to manage something like that. Honestly, in terms of a planning scenario, the best solution here was hope, and that's to hope it didn't happen. Okay. Again, just moving through the 550 megaton or kiloton information. This is the 20 kiloton surface nuclear detonation. Again, your impact point being the capital. It gives you fallout predictions, it gives you third-degree burn, second-degree burn predictions, and it reminds you where the hospitals are in terms of the scenario and how useful or unuseful those facilities will be. So again, it kind of drives back to the planning process. The district had a plan, each state had a plan. We had to try to be sure that these things were interfaced in a way that we could look at what the threat was from the inauguration and what our capacities were to manage those things. So we had to create some focus. What were the different planning efforts we could focus on? We could certainly focus on capacity. We could focus on a distribution of casualties. But quite frankly, it still comes back to hope versus planning. In some cases, we wound up with scenarios, and some of the information I just shared with you reminded you that there's no planning that will normalize an event that includes an improvised nuclear device, okay? I don't know how many of you remember the 1986 movie War Games, but the solution was the best way to win the game was to not play. And quite frankly, that's sometimes the best hope you have or the best plan you have in that particular type of event. So let's get down to reality. The reality was there were certainly real potential events that could have occurred and did give us reason to, again, want to be sure that we had a good idea of how many beds were available in burn centers, children's hospitals, and trauma centers. And our main focus was burn centers. Some of the things that we did was we went through the ABA information to find out what our contact information was for each of the southeastern hospitals, and to validate that information, because as I'll discuss later on, some of that information was not correct. It also challenged our assumptions in terms of when's the best way to collect data. Because it is a snapshot in time. Certainly it's almost a static measurement on a daily basis and not really a dynamic measurement that, you know, gives us real-time updates. But honestly, if there is a redistribution of burn patients there, or any type of patient, there is going to be some lead time, hours, maybe up to a day, before we're going to be able to redistribute those patients across the southeastern U.S. Or across the northeastern U.S. We did work with St. Barnabas. Again, there was 2 collection points of information for the northeastern U.S. It was at St. Barnabas, and for the southeastern U.S. it was us here at UNC. We did look at the ABA guideline for surge capacity because, again, that's kind of a common measurement, although I will tell you one of our findings suggested that in most cases, hospitals reported a surge capacity that exceeded what our national definition is of surge capacity. In terms of contact and actual bed capacity information, the repository of information we used or relied upon was data that burn centers are supposed to be submitting on an annual basis to the American Burn Association. We actually found that approximately 40% of the time that information was inaccurate. Generally, it was underreported in terms of number of beds that were available and being used by that service. So that certainly was promising, but we're talking about dozens, not hundreds. Also, the contact information was inaccurate. Again, it just reminded us if we have a real-time disaster and there's that much inaccurate information, it's going to be important for us to figure out who we do need to call to be able to redistribute patients. And again, kind of a promising thing was surge capacity. Most of the hospitals, 15 out of 18, did report a greater surge capacity than what our definition is that we've generally accepted as surge capacity. There was some confusion over dual use. You know, in some cases, burn centers are part of a trauma center. And so when you have a dual use, okay, well, it changes kind of what's available to your service line. The same way with pediatric patients and adult patients. In some services, they provide burn care for both adult and pediatric. In some services, it's adult only. That dual use definition was a little confusing, and quite frankly, there's not a common dual use definition that's currently out there. In terms of reporting facilities, we did speak with each of the reporting facilities, and what was in terms of a definition decided to be the Southeast. That did include West Virginia and Kentucky. For the folks from those two states that aren't sure if you're in the Southeast, that particular week you were. So, but again, we looked at a reporting period between the 16th and the 20th of January. We actually ran it on and spun it down on the 21st of January. But each of those particular days I either talked to or had an email from each of those particular facilities. Now, mind you, the 17th and 18th was a Saturday and Sunday. At that particular point, you're probably talking to the person who generally knows more about what's going on in the unit anyway, and that's the charge nurse. But it does give you an idea, a snapshot of what their actual capacity was. Now, the place that was a little bit more uncertain, though, was surge capacity. They were a lot less likely to tell you, well, you know, if you needed a surge capacity, what they could absorb beyond their stated capacity was. But again, we did talk to each of the burn centers in the southeastern U.S. The two in North Carolina, the two in Virginia, the two in Tennessee, the three in Alabama, the four in Florida. Anyway, let me move on. In terms of actual capacity, for the Southeast region, we determined that there was an actual capacity of 52 beds. And although that number's not up there because I messed up the slide, but we did determine that there were 52 beds and 112 beds in the Northeast. Okay. Mathematically, we don't need a calculator to figure out that's 154 beds, and that's not a lot of capacity for burn patients. We did feel like between surge capacity and our stated capacity, we had just over 300 beds that we could probably push into use in less than 24 hours if we had enough time through a redistribution notification. There was 3 coordination points that were set up by the Department of Health and Human Services, and the intent was, again, to evacuate patients from the DC area to those evacuation and coordination points, and then use those places to redistribute patients. Other conclusions, there's a national data tracking system that the federal government established in 2005, referred to as BARTS. BARTS captures 33 data points. It's real safe to say that there's a fair amount of frustration involved in the use of that system. That was reported by most of the respondents that we talked to. Again, if we get back to just some pretty simple numbers, what's your current capacity? What could you absorb? How does that relate to trauma patients? How does that relate to pediatric patients? And those are the things that I feel like going forward we need to develop better definitions of. As far as a transport plan and a redistribution plan, although we knew where the patients were going to go for at least a resortment, I don't think, and it's a reasonable conclusion to make, that we don't have a good plan in place nationally to move large numbers of patients from one location to another, particularly those that are critically ill or injured. Actually, okay, that's all right. Let me go ahead and talk about Southern Burn Resources. On a national level, this is what our snapshot is. In 2005, 1,897 burn beds. Okay, as you can tell, in 2009, it hasn't changed a lot other than it's gotten smaller. Okay. If we look at the number of verified beds, and generally one of the reasons that we were contacted was because we are a verified burn center, but if we look at verified beds, although it accounts for roughly 2/3 of the number of beds, and those services generally manage about 70% of the patients with burn injuries that are managed at burn units, there's still a significant number of beds out there that are not at verified burn centers. But again, those burn beds on a national level operate at about 95% occupancy. And if we look at a snapshot from our own institution, again, we generally run at a better than 100% occupancy. And you know, as I remind people in the world outside of where we live here, you know, we don't accomplish that by putting 2 to a bed. We accomplish that by borrowing off of other service lines, and that sometimes that is a challenge. So we have a burn disaster plan. That burn disaster plan is currently being revised. We do plan to use the data from the inauguration to help us with revising that information, because I think it does change some of the assumptions that we've historically made with our disaster planning. An important part of this exercise, well, there's two important parts of this exercise. Number one important part was it didn't happen. Nothing happened in a disastrous or catastrophic way to make us go, now what do we do? Okay, so that's really an important thing that happened. The second thing that happened that was also important was how do we take that information and apply it to what's going on in our world today? Okay. So again, if we look at the burn centers in the southeast, there are some verified burn centers in the northeast, but those were the facilities that we looked at. Again, graphically, when the number of burn centers are so small that you can graphically display it in this fashion, it does remind you how few centers are there. So again, applicability beyond this particular event, okay? Certainly, our demand continues to exceed our supply. It's not a problem with supply. It's a problem with our ability to manage patients in a short period of time in the community hospitals, regional hospitals, to help us with absorbing the patients. And again, the worst case scenario continues to be something that's driven by terrorism. And the reality check, Dr. Kearns and I were invited to Washington about a month and a half ago to meet with the Chief of Planning for the U.S. Public Health Service through the Department of Health and Human Services. In the month that preceded the time, from the time we were invited till the time we arrived, do you know what this is? It's H1N1. I assure you there was nothing that we could discuss regarding burn disaster that had their attention at that particular time. Washington, D.C. right now is all flu all the time. And certainly that's an important planning concept, and I understand that. But it doesn't change the fact that there are other things we have to be concerned with. Whether it's a terrorist being arrested in Colorado or somebody in Dallas that actually goes so far as to purchase what he thought was bomb-making material. The bomb was actually taken to the base of the building that he intended to blow up, and he actually used the cell phone to activate it. And after he activated it, then the FBI arrested him and reminded him that the material that he had bought, well, wasn't quite as capable of explosive nature as he thought it was. But these things are going on. And again, whether we have to be right all of the time when we're dealing with something like this, because as I've told you before, with an improvised nuclear device, there is no way to win that game. There is no level of preparation that we can take on that's going to make that work well. Okay? We certainly have to be prepared for it, but we also have to understand that when we're dealing with things like this, whether it's in New York or, did I mention North Carolina, there are people that have some really sordid intentions. Generally, it's going to include blast and burn, and when it does, we've got to figure out a way to be prepared for it. So again, as we look at the inaugural data, it does give us an idea of what we need to revise in North Carolina, and for that matter, the southeastern U.S. It gives us an idea of what are the things that we need to be prepared for. Because as we work through our responsibilities, not just in North Carolina, but in the southeastern U.S., there are responsibilities we have to work with these other institutions to be sure that what capacity we have is leveraged to its maximum capability. So let me wrap up with just a couple of closing thoughts. First of all, we have, again, we have a particular nature of event, and I'm talking about blast and burn injury, that's atypical. You know, I was at a state conference Monday and Tuesday where obviously we talked about everything in the world, but at some particular point I reminded folks to get their flu shot, just so I said the word flu like everybody else did in some other presentation. And H1N1 certainly is an important part of disaster planning and disaster preparation, as is a myriad of other things that we deal with. But there is a clear and present danger that continues to exist, and that does include blast and burn injury. We have a very small resource in our capability of managing that. If we look at total number of admissions of one of the busiest burn centers in the country, right here at UNC, you're talking about 1,000 admissions in a year's time. If I work in an ER and I see 73,000 people in a year's time, and I'm seeing 200 people a day, it's real easy for me to discard those numbers or discount the value of those numbers until I look at the length of stay and the acuity and the amount of resource intensity that's required for those types of patients. It really can become overwhelming. And if suddenly we dumped 1,000 or 10,000 or 5,000 patients with blast and burn injury into the system, it's not there in terms of a capacity to absorb it. So it does drive back to the point of the first level of preparation, just like the first level of planning. All disasters are local, all preparedness is local. So the more we can do in the community hospitals and the regional hospitals to help them feel comfortable with what really is an atypical patient for them, the better off we're all going to be. Because at some point those patients do arrive here, but they need to arrive here well taken care of and well managed, maybe hours after the event. But that is going to help make outcomes for them, and certainly services by us used to the best of its capacity. And with that, I'll open up to questions, or Dr. Kearns, if you'd like to add a comment. Okay.
We could have the lights up, please. Randy, that was a terrific presentation. Dr. Sheldon. And please repeat the question, Randy.
Yes,
for
sir.
the audience.
Very nice presentation. There's a new book out on the Coast Guard's response in Katrina, and being an old member of the Coast Guard. I had a low-level campaign to try to get the Coast Guard aside Homeland Security so that you can have career people up instead of people who were lawyers for Joyce and Horse
Sure.
Consortium. And the Coast Guard medical people are all part of the U.S. Public Health Service ranks. So I wonder how that fits into your schemas here, as far as, because there are federal facilities that are available
Sure.
under the same overall umbrella.
And the question, in terms of the question, first of all, what are Coast Guard resources? How does the Coast Guard fit into a planning scenario like this? Because the Coast Guard is a part of the Department of Homeland Security. Certainly it is an important aspect of response and capacity. Before I answer that, let me also comment about Katrina. I'll tell you folks, I was at Waveland, Mississippi on and off for about 2 months. There were a lot of things that did not go as well as they could have gone in terms of a federal response. Probably the one federal agency that stood head and shoulders above anybody else was the United States Coast Guard. Well, in part of that is because of decentralized command. Each local district has the ability to make some command decisions without, again, pardon the expression, asking permission to go to the restroom. They make decisions that save lives every day, and it's because of that capacity that things went well in Katrina. Now, for that matter, it's also because of that capacity that things could go as well, at least as they could go in a disaster, as long as we're involving the coasties. The U.S. Coast Guard at North Carolina has a large contingent of Coast Guard capacity down at Elizabeth City. We did look at what their capacities were around the area. Now, again, it's important to note that they don't nearly have the type of resources they should have, but they do a great job. And yes, they were an important part of the planning aspect of this. It does feed through the National Disaster Medical System. And although we were looking on the civilian side, certainly there were federal hospitals and federal services that were available in a part of this planning. It just wasn't a part of what we were doing.
Any other questions? Dr. Staver?
Yes.
That's a great talk. I have a couple of questions for you. So when you talk about surge capacity, what percentage of that are you planning for ICU versus regular beds? Number one. That's your questions.
It's okay.
And then number two, you mentioned H1N1, but particularly these days, H1N1 or a hurricane, have you in your models looked at what do you do when you already have beds full with something else, patients that you cannot move?
Sure.
And then finally, you mentioned making other centers comfortable with kind of treating people in situ. That's one way to increase research capacity. What has the ABA done to kind of educate people in the community hospitals about how to take care of these kind of patients?
Let me
Please repeat the question for the folks.
Sure. Okay, so let's kind of go through the questions and I didn't take notes, and I probably should have. Right. Well, in terms of surge capacity, there's a couple of things. Number one, it's really difficult. I mean, you're creating, if you had a 50-year-old male, a 35-year-old male with a 50% burn, how many of those patients could you take? Because that's in a critical patient. It is important in terms of a planning scenario that we also talk about how many patients do you want to take with a 90% burn. Just to remind folks, you don't want to take that patient. You know, I mean, let's be frank and honest about appropriate triage of patients, but you do want to look at how many critical burns can you take, and then how many non-critical burns can you take, and I'm talking about the 15 to 25% types of patients. Now, they certainly could be more critical than others because of the areas that they involve in terms of the burn injury, but we try not to get too specific with that because, again, we're just trying to get to the point of, in round numbers, how many numbers can you give us or can you not give us? Because then it does go back to your other question in talking about, you know, what if your beds are already full because of H1N1? I will tell you one experience that I've had in operating field hospitals. There are types of patients that you can put into surge hospital and a tending system as an example. And an H1N1 type patient is certainly one of them. There are patients with overnight stays. There were lots of patients, Dr. Rich was there, there are lots of patients that we could manage in a tent system for 24 hours. A patient with a serious burn is not one of them. So, you know, we need to be judicious in how we are sure that the patients with serious injuries are in a bricks and mortar environment, and the patients with, you know, certainly reasonable and important illnesses, but can be managed in more mobile environments, are available to mobile environments. And then your last question dealt with the ABA and training of community hospitals. Just looking at the national numbers for the American Burn Life Support, which is generally the stalwart burn program, I can tell you that there's significant opportunity to teach a lot more people in the Advanced Burn Life Support program. I can tell you that the 1 hour content in a typical program such as ATLS, TNCC, if you're a trauma nurse, or ITLS, if you're an EMS, that 1 hour course, or that 1 hour component of that course, it may give you some awareness. It certainly doesn't offer you a lot of familiarity and comfort with managing a burn patient. ABLS is a good way to do that, and we have trained over 800 people in that. 800 doesn't come anywhere near the 131,000 that we've identified that are involved in pre-hospital and hospital care in the emergency setting. But if we can hit 1 out of 30 in each of these facilities, that's a start.
What about these mobile mass units? We looked at that one time about just expanding our capacity by bringing in some more LICUs.
Yes, sir.
all set up.
If you could maybe add to that, Dr. Stringer's
Sure.
innovative program.
The question was about mobile assets or mobile hospitals. Actually, there's North Carolina has 8 that are a part of what's called the RAC system, the Regional Advisory Committee. The University of North Carolina has one that's based as a part of the Mid-Carolina RAC. Fully built out, it's a 250-bed. Actually, each one is identified as a 50-bed unit, but it is a tenting system with a central hub. Each of these units have basic ER capabilities, but it does work as a surge capable type unit. We've used them in situations where the infrastructure loss has occurred at a particular hospital. The hospital in Hancock, Mississippi was flooded during Hurricane Katrina, so we built a field hospital down the road from it. Again, those types of facilities exist in North Carolina. We have 8 of them spread out across the state. One's tied to each of the level 1 trauma centers other than New Hanover and Mission, which are level 2 trauma centers, but there's also one at each of those locations. I'll also add that there's one catastrophic, it was designed as a federal catastrophic field hospital. It has 8 ORs, just a litany of equipment. 16 tractor trailers are needed to be able to move the equipment. But recently, North Carolina was actually assigned that asset. We actually saw a piece of it yesterday, day before yesterday, that is 2 of the ORs. But again, the idea, it is assigned now to North Carolina. We'll either deploy it to other states with basically an overhead team and allow other states to use it. But when there's been tornadic activity that's taken away the infrastructure, the intent is, let's go back in with a hospital, let the people that's worked at that hospital work in that environment. And we can also use it for surge capacity.
I think it's designed as 8 ORs and 24 ICU beds at 250 bed capacity. It's just a technological marvel, but it requires the local healthcare providers really staff it, and it's really an amazing facility. Dr. Mendel?
Previous presentations have stressed the importance of the communication system.
Yes, sir.
Standardized for providers. Have strides been made in that?
I can tell you that limitations of our work suggest that we haven't done a good job of identifying dual-use beds. We've not done a good job of being sure that all of our information is current in terms of who to call and when to call. So communication is paramount. And not just at 11 o'clock on a Tuesday morning, but 11 o'clock on a Saturday night, because it's probably 2 different phone numbers you need at least. Excellent point, though. I can tell you that sometimes we talk about a problem more than we talk to the people that can help us solve the problem.
Randy, one of the missions of the University of North Carolina, as defined by the citizens in the state, is that we provide service, and that the people recognize that that's our goal. With regards to burn injury, a lot of times in sort of the healthcare field, the medical field, it's really kind of an out of sight, out of mind. And when you do think of it, your answer is, how do you get them out of here as quickly as possible? We've been told by the federal government and other people that the likelihood that we're going to be able to change that perception, that people will actually want to embrace understanding and learning how to manage these patients so they could be managed in a community hospital is low. So my question is, what is since you've been working with the state for so long, what is your perception of whether we're making progress in that arena? Do people perceive this as a valuable resource? Are they engaged? Do they accept those protocols? Will they use them? Do you believe that we can actually develop a system that will become functional if it's needed?
I think we can, and actually, I think we've seen some evidence of that in recent events. I mean, if you look at the ConAgra explosion, you had scene triage of 3 patients with critical burn injuries that could have easily gone 5 minutes down the road to a trauma center, but instead drove another 30 minutes to the burn center. You had paramedics that initiated care based on the standards of care that we had established a year ago. You had the provision of care at community hospitals such as Rex, which managed 3 burn patients for about 5 hours, 6 hours, purposefully so that we could create a buffer until we could absorb those patients in our system here. So I think I think there's real-time evidence that our efforts so far are paying off. I can tell you that, miles to go before we sleep. There's plenty to be done, and there's a lot more education that needs to be provided. But I'll again, because I'm kind of an old guy that I've been involved in healthcare a long time, I do wind up in some of these hospitals where somebody says, you know, I like you and you're a nice guy, but I got to tell you, if you think I'm going to sit on a burn patient for more than 2 hours, you've lost your mind. And so my next question to that is, what do I need to do to make you feel comfortable with a burn patient for about 6 hours? You know, well, education and equipment. You help me with at least identifying what equipment we need to pre-position so we can manage some of these patients. You know, it's just like I tell, I'm an old paramedic, it's like I tell the paramedics, folks, if we can get fluid resuscitation going, certainly manage the airway. If we can secure and manage the airway, fluid resuscitation and pain management, and we don't cover them with lots of water and, you know, do crazy things, as long as we're doing that, we can manage those patients and drive them to the burn center, which is where they need to be managed. And if we have any concern at all about trauma clearance, be sure we're going to a trauma center first and be sure that they're cleared for their traumatic injury.
Well, some of our closest collaborators and colleagues and the only trauma center in the state that actually sends their residents to the burn center are online with us now, the folks over at New Hanover, and we certainly appreciate all they've done. And they do live there at the edge of the ocean for the hurricane season and so forth, and they do send us a lot of patients. I wonder if anybody in Wilmington have any questions or comments, and if not, Randy, maybe you could talk a little bit about what our role might be in the event of a hurricane. Any questions from? I see a hand. Is that Dr.
Yeah. Having had the opportunity to participate in multiple hurricanes, one of the questions that comes up routinely, and more recently in light of the recent helicopter crash in South Carolina, is what is the role of the helicopter in these settings, and what directives are given to the public in this triage process in the event of a mass disaster with so many people involved. You were using the model of Washington, D.C. in the inauguration. It's hard to imagine how the public will be dealt with in the face of that setting in such large numbers. What preparation is taken for dealing with that? Thank you, Randy, for a great presentation.
And thank you, Dr. Clancy, for the question. Folks, I'll tell you, the numbers that we saw during the inauguration, you know, I talk about hope versus planning. I got to tell you, there is an endpoint of what you can plan for that you can reasonably manage. In an event where you've got 5 million people on the ground in front of a building for several hours, really exceeds what we can foresee in terms of a realistic planning scenario that we can manage. I'll tell you, some of our scenarios that we looked at in the Washington, D.C. area was, again, to build as much surge capacity in surface parking, and you know what surface parking is like in D.C., it's certainly at a premium, but to create as much surge capacity as we could there on the ground, and then redistribution of those patients for patients that were critically ill or injured. And then back to air services. As much as we can use air services to redistribute those patients because of transportation problems, you know, we would continue to use them, you know, in light of what happened in South Carolina. You know, that's always tragic. So I don't know that there's an absolute solution to any of this other than to be sure that we're doing the best we can for the numbers that we know we can manage, and for the numbers that we know we can't manage, let's look at, are there other solutions out there?
Well, I believe that's all the time we have for today. Thank you, Randy, for all your work and for your great presentation this morning.
Okay, thank you, sir. Thank you, folks.